Good morning to everyone. First of all, I would like to thank Peter, Jenny and Jean for kind invitation to come to you to Guernsey. My topic is microbiota, mainly bacteria in cancer patients and in myeloma. It's quite a difficult topic, but I will try to make it interesting. First, we will speak about the definition. What is the difference between microbiota and microbiome? We will focus on the role of the bacteria in the development of multiple myeloma. And then we will speak about the bacteria in the role of bacteria in the treatment of multiple myeloma. We will tackle also the future of the microbiota and bacteria in cancer. So first to the definition. We always see in the literature and in the most recent papers that even the scientists do mix the terms. Microbiota are all the organisms in the specified niche, and many scientists do use the term microbiome. There's the combined genetic material of all the organisms in that environment. We have just heard an excellent lecture from Rosiels. She focused on the genome. What is the difference between the human genome and the human microbiome? Human genome is inherited. It's largely static, despite we can see some alterations and genetic mutations acquired during the life. However, the human microbiome does develop during the pregnancy and then early on is acquired and changes dynamically throughout the life. The genome does consist from less genes compared to the microbiome. The microbiome contains approximately 20 million genes. There was a very nice paper published in 2013, and they described the large intestinal microbiota as forgotten organ. It's little known about it. And not many, even doctors, still think about the importance of bacteria. The human intestine contains around 100 trillion of intestinal microbiota, and in adults we can identify more than 800 different species of bacteria. Also, it is important to mention at this point that anaerobic species do outnumber the aerobic ones significantly. Also, the culture is successful in 20% of patients. When we send off cultures when someone is septic, we can suspect that the success rate of cultures will be around 20%. We are still missing a lot of microbes. We do have other methods how to identify presence of bacteria, especially in the guts. Jan will speak about them, but these are not usually used in the clinical practice. Further, we need to also acknowledge that we speak about intestinal microbiota, but we mainly know about bacteria. We know very little about viruses, about archaea and other types which we have in our guts. This is another limitation which we need to acknowledge. Now, the role of intestinal bacteria, which I will speak mainly, I'm not going to speak about viruses as our knowledge is so limited, is great. The bacteria clearly play a role in obesity, diabetes, as well as NASH syndrome, neuropsychiatric disorders. And because we are based at Marsden and we are invited by the myeloma group, we will be speaking about the role of bacteria in malignant diseases, mainly about bacteria in multiple myeloma. We do come from Royal Marsden Hospital, and this was the first hospital which was dedicated to the study and treatment of cancer. It was founded as a free cancer hospital available for any patient in 1851. You have the picture of William Marsden, who founded the Royal Marsden Hospital. And he was the one who told his friends during the meeting in his home, now gentlemen, I want to found a hospital for the treatment of cancer and the study of the disease. For at present time, we know absolutely nothing about it. And that was 1850. He was born in Yorkshire in 1796. Then he studied in London. And later that year, after he graduated, he found a very young girl, almost dead from starvation disease at the steps of the St. Andrew's Church. He wanted to have her admitted, but did fail and she died 2 days later. At the time, the admission to the hospital was possible because only a letter from a hospital governor could make it. Now, this was a turning point for Marsden. He opened a free institution, which then was renamed in 1837 after the Queen Victoria granted it royal charter, after Marsden treated all the patients free, despite they even had the outbreak of cholera at that time. The hospital was then renamed and it is Royal Free Hospital, the famous hospital in London. Now, another turning point for Marsden was that his wife died very early on because of cancer, and then he founded second free cancer hospital in London in 1851. So we can see how advanced he was in his thinking, and we can see the free access of all patients to the cancer hospital then. Now we will speak about the bacteria and multiple myeloma. Multiple myeloma is always preceded by monoclonal gammopathy of undetermined significance. Now, there are 3 possible pathways how the multiple myeloma develops. The first pathway seems to originate from chronic infection, which is caused by the pathogenic bacteria. An example could be HCV infection, HIV infection, EB infection. If we were able to give an appropriate treatment, for example, antibiotic or antiviral medication, we would be able potentially to stop the development of the multiple myeloma from MGUS. The second pathway involves the autoimmune disease. So if someone has autoimmune disease, can develop MGUS, and if we were able to cut this pathway, we probably were able to prevent the development of the multiple myeloma. The third pathway, which is not that well known yet, there is not enough knowledge, but seems to be very probable, is that even commensal microbiota, means bacteria which are in our guts normally, they are not pathogenic, they can work as antigens, and MGUS still can develop. And then the question is, would we be able to prevent the development of the multiple myeloma using prebiotics or probiotics or fecal transplant? That's a question for the near future. So as I said, if we were able to reduce the load of the antigens of microbial origin, we probably were able to be successful in the treatment. There is a very nice paper published from 2013 when they were able to achieve regression of multiple myeloma in a patient with antiviral treatment when he was treated with HCV. So that was the first pathway which I introduced. To have a little bit more understanding how it works in our guts, the intestinal microbiota do communicate with our immune system. They allow our system to develop. Very simply said, we have our colon, large intestine. We have a lot of bacteria in the lumen as well as in the mucosa. The mucosa microbiota are even more important. And they do interact with the antigen-presenting cells in the lamina propria. They allow them to develop further, and then the lymphocytes, they differentiate, they produce immunoglobulins, or they can differentiate into plasmatic cells. So this is the system how it works in our guts, just to have the background. Now, different differentiation can happen. There are, for example, some bacteria which stimulate the lymphocytes into T helper 17 cells, that they can produce interleukin 17, which can lead to the progression of multiple myeloma. So the microorganisms in the guts can be the stimuli and can lead to the activation of antigen-presenting cells, and then they present the antigens to the lymphocytes, they develop further, and they lead to the progression of multiple myeloma in the bone marrow. So there is a background behind that, and we can acknowledge that the bacteria clearly play a role in the development of multiple myeloma. To understand a little bit better the background, we have 4 main phyla in our intestines. Firmicutes, Bacteroidetes, Actinobacteria and Proteobacteria. Everyone from us, I can guarantee, has these 4 phyla in the small and large intestines. In multiple myeloma patients, we can observe that there is clearly a dysbiosis. We can observe there are alterations in these 4 phyla. Not only some of them are abundant, but there are also some species out of these phyla very abundant. If we observe abundance, for example, in Klebsiella, then we can see that not only these species are rich in our guts, but they also produce the metabolites which are not safe and which can contribute to the development and progression of multiple myeloma. This is a very nice and quite simple scheme. We can see that this Prevotella can lead to the differentiation of Th17 cells, which I mentioned, production of that interleukin, and then progression of multiple myeloma in the bone marrow microenvironment. We also will speak about Klebsiella once again. This is a nitrogen recycling bacteria which contributes to the progression of multiple myeloma. And we also will speak about short-chain fatty acids. I think everyone has heard about butyrate. If we don't have enough butyrate, short-chain fatty acid, we can activate, or our cells can activate NF-kappa beta pathway, as well as we can produce cytokines which are again leading to the progression of multiple myeloma. Short-chain fatty acids are really very interesting metabolites. We will speak mainly about butyrate. They are produced during fermentation of the fiber which we eat. And there are some specific intestinal bacteria, and I will speak about Clostridium butyricum, which leads to the production of the butyrate. Butyrate is an anti-inflammatory molecule. It does inhibit production of pro-inflammatory cytokines. It does induce, on contrary, the expression of anti-inflammatory cytokines. I mentioned the NF-kappa beta pathway already. This pathway was discovered in 1986, very important one, which leads to the carcinogenesis, leads to the inflammation, and butyrate can downregulate this pathway. Further, butyrate can inhibit histone deacetylase in colonocytes. That means it does induce apoptosis, programmed cell death, which is needed, for example, in the adenomatous tissue. Now, in multiple myeloma patients, it was found out that there are significantly reduced levels of short-chain fatty acids. As a consequence, we find high levels of inflammatory mediators in the bone marrow environment. You saw that was the last step. And now question is, would we be able to prevent the progression of multiple myeloma if we changed the bacteria in the small and mainly large bowels so that we would increase the production of the short-chain fatty acids and would reverse the microenvironment? I will also mention the nitrogen recycling bacteria. This seems to be a little bit complicated, but I will explain it. It is quite straightforward. The glutamine, which you can see here, is the preferred energy source and source of the how the cancer cells can multiply. They need it for the nucleotide synthesis. So they use it in the cycle. However, as a consequence of this cycle, ammonium is produced, and the cancer cells, they can't use it in the bone marrow. So the ammonia is getting back to the vessels. It can get through to the liver and the kidney, and it reaches the intestine. And now if the multiple myeloma patients have a lot of nitrogen recycling bacteria, which you mentioned already, including Klebsiella, the semi-clever nitrogen recycling bacteria do recycle the ammonia into the glutamine. Glutamine gets into the blood vessel, gets into the bone marrow, and is again the source for the cancer cells. And clearly the multiple myeloma patients have enough abundant in nitrogen recycling bacteria, and that's what can cause or contribute to the acceleration of the progression of multiple myeloma. Now we are moving towards the treatment. The microbiota and bacteria are also important in the efficacy and side effects of the treatment. First, we will speak about the hematopoietic stem cell transplant. It was confirmed that the patients undergoing transplant have lower fecal microbiota diversity just before the engraftment and during. And this is associated with the impaired response to the autologous stem cell transplant. The patients who are undergoing transplant, they are in a decreased risk of death and progression of multiple myeloma if they have increased diversity. Also, we know that the abundance of beneficial bacteria, including Faecalibacterium, and I will speak about it, is associated with minimal residual disease negativity. And patients who have a good composition, better diversity, more broader diversity of the microbiota, have less side effects, including nausea, vomiting, neutropenia. Now, from our clinical practice, we quite easily give antibiotics, and we do impair the diversity of the microbiota. And the question is, do we really need to give antibiotics in borderline situations? Because we decrease the diversity and we impair the outcomes for a patient. So do we need to be more cautious with the antibiotics as well? I mentioned Faecalibacterium. That's a very interesting microbe. It's very abundant in healthy individuals, representing more than 5%. Very difficult to cultivate. And I have mentioned it because it is a major producer of butyrate, and we are coming back to the short-chain fatty acids. We are moving to CAR-T treatment, which is not yet used in multiple myeloma, but it is a very smart treatment developed recently. Chimeric antigen receptor T-cell treatment. Explained more simply, we can isolate the T lymphocytes from the patient. We modify genetically. We add a receptor on the T cell, and then it's multiplied, then injected back to the patient, and then the receptors are recognized, or the receptors are recognizing the proteins on the surface of the plasmatic cells, and then the plasma cells dies. So that enhances the immune response in a patient. It has been shown that also bacteria play a role in this context. The efficacy as well as the toxicity of this very advanced treatment can be influenced by the baseline bacteria. So this is once again the explanation. As I said, T cells taken from the patient, genetically modified, returned back, and it enhances the immune response of the patient. We are moving to the last treatment, which I would like to mention is the immunotherapy. You know that there are a few generations available now. The plasma cells in multiple myeloma patients, they express PD receptor, programmed cell death receptor highly. However, it has not been shown that the treatment would be effective, at least not as a single agent. There were also some combination treatment used, with lenalidomide, with Velcade, but there wasn't a better response still. On contrary, it even resulted in higher toxicity. Is it because of the bacteria? I would like to show you a few pictures. We know that there are several toxicities caused by the immunotherapy. The most common one is immunotherapy-related colitis. These are the pictures which I see, or which we see endoscopists during colonoscopies. These are normal pictures. This is the cecum, appendiceal orifice. You can see triangle, that's the transverse colon, and the cecum. You can appreciate presence of normal vascular and mucosal pattern. If we move to these pictures, these are the pictures in a patient with immunotherapy-related colitis, and you can appreciate absence of mucosal and vascular pattern here. These are aphthous lesions, which are present in patients with immunotherapy-related colitis. A lot of mucus. We can see excessive production of mucus in these patients. And these patients had hemorrhagic colitis, also with a lot of ulcers. They even didn't respond to biological treatment and ended up with colectomy. So these are the side effects of immunotherapy, sometimes seen. There are studies showing that the patients do respond to immunotherapy and develop side effects, and it depends on the baseline microbiota. Patients who had ipilimumab and had more bacteroidetes in the beginning, they were more resistant to develop colitis. On contrary, if the patients have more Faecalibacterium, they respond better, but they also develop more colitis. So the bacteria play a role in the response as well as the side effects are dependent on the composition. Now, what is the future? Shall we be giving probiotics or prebiotics, or shall we be providing fecal microbiota transplant before any treatment is suggested? We will speak briefly about the definition of probiotics, prebiotics, and fecal microbiota transplant so that we can have an idea if we should be using it. The probiotics, as per the definition, are live microorganisms which are administered in adequate amounts and then they confer a health benefit on the host. We know from when we go to the pharmacies, usually it's lactobacilli or bifidobacterium. The question at this point is it safe to give it to the patients who are quite heavily immunosuppressed sometimes during our treatments? It seems to be safe, but there are some case reports, especially in early born babies, that if they've been given probiotics, live microorganisms, they could have developed opportunistic infections. So I think more knowledge needs to be gained in this field as well. The most well-known probiotic is E. coli strain Nissl 1917. And now you can see on the left side, Professor Nissl, he was the one, that's why it's called strain Nissl. He discovered this strain in 1917. And the story goes back to the First World War, when Alfred Nissl looked at the feces of the German soldier who was moved to current Bulgaria. And he didn't develop a diarrhea like the other ones because he was protected by the strain E. coli Nissl, which was antagonistic to the Shigella, which was there spread in Bulgaria. All the other soldiers did develop diarrhea, not him, because he had this E. coli strain Nissl 1917. The best well-defined probiotic at present. Now we move to prebiotics. Prebiotics are usually taken as dietary fiber. For example, we know lactulose. This concept was introduced in 1995, and the definition says it's a non-digestible food ingredient that beneficially affects the host by selectively stimulating one or more bacteria in the colon and therefore improves the host health. There are other criteria. The prebiotic should be resistant to the pH in the stomach, can't be hydrolyzed by the enzymes, should not be absorbed in the proximal gastrointestinal tract, then it can be fermented by the intestinal bacteria, and then the growth and/or activity of intestinal bacteria can be selectively stimulated. For example, if we give lactulose, it stimulates the lactobacilli, or Faecalibacterium, then it produces butyrate, which is beneficial for the individual. Now we get to fecal microbiota transplant. I did see it for the first time in 2013 when I've been to a short stay to Leeds. We had a patient who had recurrent severe C. diff infection, who always ended up in severe sepsis. And then she underwent fecal microbiota transplant and she was fine since. Fecal microbiota transplant is administration of a solution of fecal matter from a donor into the intestinal tract. The aim is to change the microenvironment quickly, and it should confer a health benefit. We need to select the donor very precisely. The donor can't have any family history of autoimmune or metabolic disease or malignant disease, obviously. We need to screen for any potential pathogens. We usually do it via the NJ tube, gastroscopy or colonoscopy, either into the terminal ileum, usually it's sufficient into the colon. And this has been used mainly in C. diff infections, as I mentioned already. And the question is, would there be a role for fecal microbiota transplant before any treatment for malignant diseases is considered, or in other indications including IBD or obesity or GVHD, where we know that the bacteria play a huge role as well. What is the future? Shall we be manipulating with bacteria using these potential options? Should we be using antibiotics less? Would we be able to prevent the development of MGUS and multiple myeloma and slow its progression? Would we be able to improve the therapeutic outcomes? And shall we be able to increase the chance of minimal residual disease negativity? We would be potentially able to use the microbiota as a biomarker as well, which is a big chapter now. We only have evidence from very small, limited, single-center studies, and we mainly use 16S RNA methods, which will be explained a little bit later on. We can't identify viruses. We are limited to bacteria at this point. However, we think that the bacteria could be used as a biomarker. And a very simple example could be that we would be able to measure the butyrate as a predictor, as a biomarker for sustained MRD negativity. Ladies and gentlemen, I would like to conclude. We looked very briefly at the microbiota, not microbiome, and mainly bacteria. We looked at the role of the bacteria in the development of multiple myeloma. We covered a little bit bacteria and the role in the treatment. And we spoke about probiotics, prebiotics, and microbiota transplant. And the question remains, would we be able to use it in the near future, and should we be focused on it? Thank you very much.